Hello, everyone. I'm Carmen Pugliafito, and I'm here today with Dr. David Boyer, who's an adjunct clinical professor of ophthalmology at the Keck School of Medicine of USC and a well-known clinical investigator in the retina space. David, welcome back to Retina Synthesis.
Thank you very much for having me, Carmen.
Today, we're going to talk about the use of high-dose Aflibercept in the treatment of diabetic macular edema, the so-called PHOTON study. Can you tell us a little bit about that trial?
Yeah, it was a phase 2-3 trial. It was an international trial. They were able to take Aflibercept, 8 milligrams, and put it into 70 microliters or 0.07 milliliters of fluid rather than the 0.05. The same medication, but 4 times, the higher molar concentration, with the idea that the higher molar concentration would allow for a number of increased half-lives and longer time duration that the drug would be available. The study was fairly simple. It compared a 8 milligram dose given every 12 weeks versus an 8 milligram dose given every 16 weeks against the 2 milligram Q8 dose that was the standard and is on the label. So essentially what happens is that on the label, Aflibercept 2 milligrams was administered 5 times every month for 5 injections, whereas the 8 milligram dose was only administered 3 times. The patients were randomized 1 to 2 to 1 between the 2 milligram dose, the 8 milligram dose given every 12 weeks, and the 8 milligram dose given every 16 weeks. And there were over 650 patients in the study. So it was a fairly large study. And it was the key eligibility criteria were fairly standard for almost all our diabetic trials. The patients had to be type 1 or type 2 diabetic, have diabetic macular edema. The only major difference was that they allowed the presence of relatively good vision, 20/32 vision. So there would be a ceiling on how much vision could be gained even with this treatment. The treatment regimen, as I said, was 5 initial doses at the 2 milligram. The 8 milligram had 3 doses, and then they were administered at 12 weeks or 16 weeks. Now, if the patients met retreatment criteria in the 12-week dose or the 16-week interval, they were allowed to go down. They were never allowed to go up. So a patient could go and have 3 treatments, receive the next treatment 12 weeks later. If they were dry, they couldn't advance to 16 weeks. They could only go down if they were leaking. And the retreatment criteria was 10 letter loss and 50 microns increase in fluid. So there are various time points where the patients could go down, but no time point where the patients were able to go up. The patients completed the study. Over 90% of patients did complete the study. Very few patients dropped out. About 75% of the patients were hypertensive. It was a typical group of diabetic patients that we normally see. And over 40% of the patients actually had previous treatment. One of the secondary endpoints that was important was the baseline diabetic retinopathy, or the change in diabetic retinopathy severity. And in this study, unlike Panorama and other studies, the patients, almost 60% of the patients, had 43 or less or better DRSS scores compared to Panorama, where they only looked at the 47-53s. Mm-hmm. The primary endpoint was, of course, vision between the 2 groups, and there was no difference despite the fewer injections at the end of 48 weeks. And this I should remind everybody, this is a 96-week trial with a possibility of even going a 3rd year to see if we can go longer. And so the results were very comparable to what we are now given as 2 milligrams every 8 weeks. They were able to extend patients to 12 or 16 weeks. This was not driven in any way by whether the patient started with poor vision. As you've pointed out many times in articles, when patients start out with poor vision, they are able to gain more vision, though they never possibly get back to 20/40 or better vision. This was the same whether they had better than 73 letters or less than 73 letters. All groups gained vision appropriately. Same was true whether the whether the patients had a very thick CRT, a central retinal thickness at baseline, or if the baseline was less than 400. So all groups did improve. So there's not one group that drove this. It wasn't a group that had very thick retinas and very poor vision that got better. These were all comers that basically improved. As one would expect, the diabetic retinopathy severity did improve, but not very much because, again, over 60% of the patients had relatively good diabetic retinopathy severity scores. But if you look at when the patients were 47 or 53, they had the same results that you got in Panorama, with over 75% of patients getting an improvement of 2 steps in the diabetic retinopathy severity. Most patients stayed in their swim lanes. In other words, as the study went on, most patients stayed there. There were patients that did regress. The safety, which was extremely important because you're giving a much higher dose. There were no systemic changes. There was no signs of increased APTCs, no hypertension, which has been pointed out by you and others that does go up with anti-VEGF therapy. The IOP remained the same. There was no cases of endophthalmitis. Overall, the results were fairly encouraging. 91% of the patients that started at Q12 weeks maintained Q12 weeks. 89% of the patients that were Q16 weeks maintained Q16 weeks. So if you look at overall, 93% of all patients were able to go 12 weeks or longer in this study. So it does show that with fewer injections, we can get the same visual result as they could using the dose of 2 milligrams every 8 weeks that we're currently using.
So this study lasted how long? These are the results over what period of time?
The results that I gave were 48 weeks. The study is still ongoing. It's going to be a 96-week readout, and it's probably going to go on for 1 more year after that.
So how many injections on average did the 16-week patients?
Well, you figured out they had 3 injections and then they were given 16. So, as compared to the people who received 5 initial injections per label and then received it every 8 weeks. In the first year, there's not going to be a major difference. I think it's going to come in the second year, obviously, when you're treating every 2 weeks versus every 16 weeks, every 8 weeks rather than every 16. That's when you'll see a significant improvement. And you're doing this and obtaining the same visual result that you're getting with our current therapy that we're using.
So do you think the treatment algorithm for Aflibercept and DME will change?
It really depends on what the company, how they price it, to be honest. If they price this extraordinarily high, people continue to use. You have biosimilars coming down the market, at the 2 milligram dose. So I think that's still up in the air of how people use it. I mean, certainly, I would like to say that patients who are difficult to treat, and you've had them and I've had them, where they only can go 4 weeks and you keep retreating them and they still have edema, those patients may significantly benefit from having this extra molar concentration. We may be able to take some of those 4-weekers and make them every 8, 10, 12 week, patients. I think that, again, it's going to depend on the price, the availability of the drug to your patients, of what you use.
This is exciting. Do you want to comment about the PulseArch study at all?
I really can't. I can tell you it was a similar design, a similar type of treatment. It showed that you can go longer, but I didn't participate in the study. It's one of the few studies that, that I didn't participate in. So I really can't comment because I didn't follow it that carefully.
Well, this is exciting. We have lots of approaches for improving durability, such as faricimab. So how do you think this compares to faricimab?
That's a $64 question, Carmen. You didn't want to put me in the hot seat too high. I don't know. Basically, faricimab has a much higher concentration of an anti-VEGF than the Lucentis had. The addition of the bispecific may add, certainly may add something. If you look at the Zivacumab data and if you look at the faricimab data, there was a slight separation early between Aflibercept 2 milligrams and Nisvacumab, and also between Faricimab and the Aflibercept. But how that's going to hold up over a long period of time, I'm not really sure. You may come out of the gate a little faster, and maybe there's a little bit better drying in the beginning, but will it make a difference to our patients as far as the vision? I don't know. The only people who want to do a head-to-head study would probably be the diabetic retinopathy people who, are giving us some phenomenal information. I don't think that the companies want to do a head-to-head at this point.
Well, thank you, David. This was very exciting news. Changes are ahead, and the treatment burden will decrease.
I hope so. I hope it's better for the patients overall. The treatment burden is one thing for the doctors. It's one thing for the patients and their caregivers. So I'm hoping that will happen.
Thank
Thank
you.
you for having me.